Welcome to Bart's Heart Centre here in London.
Cardiac arrest by his wife earlier today, complaining of shortness of breath, left the house, took his asthma pump and then collapsed. No bystander CPR for the first 5 minutes. On LAS arrival was an asystole. CPR promptly commenced, had a further downtime of 10 to 15 minutes with intermittent ROSC with pulseless VT. In total, he's had 2 shocks for pulseless VT and 4 mini jets of adrenaline. His blood pressure is 230 initially on ROSC. His ECG shows inferior ST elevation with reciprocal changes in AVL. There's a further ECG that shows a left bundle branch block type pattern. His LV functions on a V scan suggest that it's severely impaired with no evidence of aortic regurgitation. He has been not loaded on any antiplatelet therapies. He's been intubated on arrival, although he is making some spontaneous breathing efforts. He's hemodynamically stable at this point in time, and the plan is for an angiogram query proceed. I'll move it on to the operators.
His periphery shut down, so you just go groin. Okay, so can we prep the groin, please? For me, standard practice is to do a groin shot up front to see whether there's any access problems, any low puncture like here, any bleeding issues. But there's got a low puncture, but very acceptable for an angiogram, and we can move on. It's a large caliber vessel, so although we don't tend to put the angiocells in below the bifurcation on this type of case, I think it'll be reasonable. Standard practice then is to take the not what we think is the non-culprit vessel first. Can you follow me up to the heart? And in which case, with the inferior ST elevation, we're thinking that's a right coronary issue. Okay, spider please. And we can see that the distal right is filling retrogradely. There seems to be a high OM intermediate with significant disease. Let's come, PA caudal. Yep. Where's the catheter, guys? Line it up a bit higher. Alright, let's take that. Good. REO caudal.
JR4 and L1.
Yeah, let's a JR4 guide. And
JR4 guide, please.
And REO cranial, please. If you, as close to 40-40 as you can. And PA cranial as steep as you can. Can I have a wet swab, please? Thank you. Line us up. That's it. Ready? It's very tight there, isn't it? Okay. Should we go with the guide to the right to see what we're dealing with? We've got a wire for me.
But we can wait to be proven otherwise.
Mag up. Ready? Okay, let's have a wire, please. Choice floppy. So, have we given the IV aspirin then, guys?
Is aspirin on board?
We're going to give some heparin now. So we've got an estimated weight of 100 kilos here.
10,000. Heparin?
10,000, yes, absolutely.
It's 10,000 of heparin. I'll have a 15-minute clock, please.
And we've got our specific protocols for the pandemic and COVID. This patient has had a fast test.
He's had the rapid Abbott ID fast test, yes.
Yeah.
Which should be back in sort of 10-15 minutes, which
Excellent.
will...
And so we're all in full PPE as per the protocol here. Good. So as we can see, there's occluded right coronary artery just after the
No, thank you. No.
bend there, which was filling retrogradely from the left.
That's
Let's
a
have
sign
that. Let's have a sign blue then.
And have we got integral in? Please, yeah. I'll give the first bolus IC and then the second one IV, please. Just for quicker mechanism of action, as we don't have any second antiplatelet on board.
I'm probably going to need the choice properly.
Yeah.
The curve here is right. They're all right.
Sure. Do you have I'm assuming the vessel wires, do you have a preferred strategy in terms of we're going to thrombus aspirate, we're going to pre-dilate, we're going to direct stent? What would make your decision?
So first, give me a little injection and then I'll explain my strategy. Is very toothless. It's very simple. I try to do as little manipulation of the vessel, whether that's Tesla,
that's the top branch,
as possible. So if I can direct stent, I will. I think that with a thrombus burden, there's often quite a bit of clot disseminated, and the idea is to recanalize the vessel and keep it recanalized rather than risk the no reflow. If there is a lot of clot burden, I do aspirate. Trust me.
Yeah, that's good.
I might need a short balloon if you have one, please.
How short do you want? 208, 212?
2.5 by 12 or 15.
Okay, 25, 12 semi-compliant balloon, please. We're working off 100.
Dan, just show me where we're at.
Yes, please.
There's a little branch here that's...
Yeah, should have come to REO.
Yeah, let's go, or go to 2020. And give me a test here. Can I have the screens a little bit closer, please? Can you test again?
Thanks, Rodden.
Go REO. Let's go back to the 2020 view.
There's a poor LB function and it's raw collateralized. This might be a CTO. And this is just it did have inferior elevation.
Looks like it's pointing in the right way here.
Yeah, that's the thing, it just buckles there. It's not.
Go on then.
You're on it, I mean that's made some progress.
Just give me a balloon. Sure.
Thanks.
So at the moment we have a blocked right coronary that's behaving a bit like a chronic occlusion.
CTO, yep. An unexplained arrest and 3 vessel disease.
Yeah.
With poor LV function. So this may well just be primarily an electrical issue, I guess. You don't have a history of chest pain.
Looks like it might be in the right direction.
No, I think you're in the right way. You're in the right way.
Let's have a look where we're going.
Yeah, I mean even with the balloon support, it's still think we probably could switch. Let's see.
Yeah. Let's have another wire then.
On trade choice.
Yeah.
So obviously the cyan blue is not where you've switched to a choice. Is there, what's made you choose the choice?
So choice is my workhorse wire. I always think it's important to use the equipment that you're most used to. Equally, it's got a soft tip end, which I think is a lot gentler to the vessel. The cyan blue has a slightly more stiffer end, which makes it very easily manipulable and turns corners. But I think that, and I like cyan blues. I feel that the choice is a better feel for me on vessels. Let's have a talk here. And it's really what you're used to, I believe.
Of course.
What next if we're not getting past here?
Yeah, and I guess if the choice doesn't work, we can try a slippery wire, as in a whisper or something, to see if something will slip through. But I suspect if we're struggling with multiple wires, that perhaps this isn't an acute occlusion.
No, I agree with you.
Changing strategy.
My next wire would be a whisper, a slippery wire. And of course, the other option is that I have another expert operator to my right who can have an attempt.
Yeah.
Alright, so you're not making much headway here, I must admit.
No.
I'm going to take the cyan blue out.
Yeah. Still okay. Right, whisper.
Yeah.
Because there's the option of a microcatheter with the wire for support, but I guess if we're heading down that trajectory, it's probably not an acute occlusion.
No. And so the question is that done? So what do you think about the data at present in intubated shocked patients?
Yeah, I think
intervention.
if this was, we've got the talker. Who's got it there?
Yeah, that can give you.
If this is we successfully treat the culprit, then we probably should leave the bystander disease for an intervention at a later date, assuming he recovers neurologically. There's obviously a possibility of brain injury with the lack of CPR, and the data supports revas, but assuming they survive, well, assuming he does well as an inpatient course, I wouldn't fix the LAD or the bystander disease now. Do you want to do an ACT? ACT time.
Okay. Go on then. I'm just pulling the choice floppy a little bit behind. So of course I think I'm in the right plane.
Yeah, I think you are.
Just moved a little bit. Yeah. Catching at this point here. So I agree, a microcatheter or a balloon. Let's go to REO now. And let's see another image. So we got a pressure around 100. His pressure's a little lower. Inject. It looks like we're sitting at just that tip of an occlusion. I think this is a branch that's coming off there. And we need to go straight down, but the imaging here is not easily visible. So I need to go back to the other view, please, the LAO.
187? Okay.
Let's give some more heparin.
Then. I'm sort of holding on the integralin because I'm not convinced we're going to be...
Okay. So this is not going freely now. I don't think I'm making much progress. So we got now move into more advanced techniques to cross or reassess.
Yeah, I mean, I think based on the history, in terms of arrest without chest pain and an ECG that's now at baseline, I'd be...
That's the whisper you've got there. Yeah, so we've got a scenario now that we've had a gentleman that's arrested. He had some inferior ST elevation with reciprocal changes in the lateral leads. It appears that he's got a retrograde fitting right that seems challenging to cross, and so it may well be chronic here.
Yeah, I guess that leaves whether we're missing a different culprit.
Yeah, and then he's got disease. Should we take a picture, see whereabouts we're at the moment?
Yep.
So it looks like the vessel is slowly recanalizing now
It
there,
does,
Dan.
actually.
So I think that there may be a combination, potentially, of clot and stenosis.
Yeah, I agree. I mean, there's more visible vessel than there was
And
previously.
certainly the ST segments have come down now. I think it might be worth using a little balloon first. We couldn't use a microcatheters, just passing it on to
Well,
the...
we take a microcatheter and
Yeah? Okay, let's have a microcatheter then, please.
take a Corsair.
Fine cross, or would you have a preference?
Corsair, yeah.
Corsair then.
Mainly because then we can screw it through. Fine cross, I doubt we'll get across. Should we give the integral in?
Yeah.
And more heparin, actually.
There's another 5,000. Guys, just pushing back. Be careful.
No, similar thing. Just buckling.
Hmm?
Just buckling even with the microcatheter.
can
It's
see.
relatively well committed. Try and have a fiddle with the whisper, or
Yeah.
should we check a different one?
So I think that what I see here is a relatively stable patient at the moment.
Yeah.
The ST segment's down, he is intubated. His pressure is lower than it was. That concerns me a little bit, but this is more in keeping with his LV dysfunction.
Yeah, true.
And so we have a little bit of time to see whether we can get this across. I think the Corsairs or a microcatheter is a good idea. I find that we'll either make a channel here. Oh, that's what we wanted. Let's get this back in. LAO, test for me there.
And this one. It's the end of the wire, isn't it?
Let's have that whisper. Okay, Dan. Look where I'm at now.
Ah, what's that?
So the question is, am I in the true lumen? It's certainly wiggling quite well.
Yeah. Okay.
Why is the rhythm like that?
It's running, isn't it?
Should we do a picture?
Yep.
So I'm not quite sure here, so we have some
No, I'm not sure.
options.
Want to take another view?
Yeah.
Come to 2020, please.
Line us up. Very difficult to say here, isn't it?
It's very hard.
So we could try and advance the course
So
further.
yeah, we could commit the microcatheter.
Can I go back to LAO? Unfortunately, the imaging here, I cannot clearly see the distal wire. It's certainly moving freely.
Yeah.
Right,
Yeah,
I'm going
I
to leave
agree.
that there. Let's see whether this moves freely without spinning it.
Okay. Well, that was really easy.
So that looks really good. So we've got a choice. Should we inject down the Corsair or should we take it as we've passed? It certainly does move smoothly now.
I mean, it's moving very freely. Well, that suggests we've gone around the back of the calcium, but I mean, you're picking up branches with the wire. I mean, I guess we're committed either way now.
Yes.
Whether we exchange for a different wire and balloon, or whether we inject. We can inject and be sure of you.
Well, we've got Whisper MS.
Yeah.
The wire seems to, you know, I'm happy to change for another wire, but I don't know whether that is a benefit. What's the disadvantage? It's a slippery wire.
No, we can just work with things.
Yeah. Should we get the Corsair out then?
Yeah. You'd hope that we'd have some flow. So can I have a 2015 trap balloon, please?
So it looks like we're in a little branch.
Just in the side branch. Vessel's open there. We're across.
We're across, and we're in the PDA, a high bifurcating PDA, do you think?
Yeah.
Should we leave the wire in that position at the moment?
I think so.
And then we can
and then we can move it.
treat the proximal bit
Yeah.
and then decide what we do further.
Okay.
Good. All right, well let's trap this.
Okay, well we'll trap out the Corsair and then do an ACT after that.
So can we have the integral in, please? And we're going to do an ACT. We've now given 500 of Aspen IV. Thank you. And we've got a COVID negative on the fast
So that's
test,
the ACT.
and his
So
blood
don't
pressure
flush.
is
Don't
relatively
flush it.
stable at 100 systolic,
We've got a flash syringe, please.
and we have a
Okay.
wire across the lesion.
Great.
That's good. And down when you're ready. So that's better. Any more? Should we come here?
Yeah.
And there? Is that you giving more metaraminol? Or is...
Yep.
Okay, so what have we got there? Have we got an effusion going on or something? Should we take a picture?
Yep.
The distal vessel. Not so obvious now, is it? Clot's moved.
No, do you want to
Go
go
on
there?
then, go up there. And down. And up. And down. It's a tight narrowing here, isn't there? And there. 2, 4,
6, 8.
down. Okay, so there is clot and what appeared to be a chronic occlusion, didn't there?
Yep.
So, we've ballooned up with a 2.5.
Yep.
We don't know his status in terms of antiplatelet.
In terms of stent choice.
Yeah, exactly.
Yeah,
Whether
no.
we go with a 1 month drug-eluting stent or one that needs it for longer. There is some reasonable data on the others, but I think as we've got the 1 month ones, we go with the 1 month.
Yeah, I agree. I think that
And
makes sense. We don't know.
what length and size of stent would you like? Back a picture, please.
No, I think we're long, aren't we? Probably 2.5 long post
Back, back another. Back another.
And it's 3 at the top.
That's 2.5. I think at least a 2.75 or 2.5 or 3.
Oh, it's definitely 3 at the top. It's just you can get you get a 3 in down there. That's fine. 2.75 would be
So,
again okay. I mean, a 2.5 synergy you can take up to 3.5.
alright, 2.5 or 2.75. I would go 2.75. Let's
Okay.
go in the middle.
Okay.
The longest 2.75 synergy you have.
Probably 48. It's
So,
just back. You come back to the.
I think so, don't you?
Yeah, I think I come back to where that branch comes off. I think it's a good distal landing zone there.
So now looks good.
Yeah.
Go on then. Good. So nominal pressure's dropped a little bit.
Thanks. It's 11. Yep.
Yep, nominal.
Yep.
13.
Yep.
It's not gone up in that middle bit there, is it?
We'll go a bit more. 14.
Yeah, just wait, we'll have to do it with
Check it and see.
So we have that middle section that we did balloon with a 2.5,
Yeah, we did.
but it seems not to have fully gone up. Let's just wait a bit, let's see whether the pressure does it. A little bit better. Should we go down and let's get a non-compliant balloon?
275, 3.
Yeah, 275 by
12
20.
or 20. Okay, it's 14.
And down. Is this a 275? Let's get a 3 by 20 for me. Good, it's opening up gradually. Let's now get this.
16, 18.
It's coming up.
Yeah,
Right.
and that's. Yep, 18, 20.
That's better.
Oh,
Now
that's-
it's up. Right. Let's do just this last bit here. And down.
Do another ACT.
And the 2B3A is running, the second bolus?
Yes, it's running. You want the infuser?
Yes,
Yes,
please.
please.
Yes, please. The rhythm has changed, guys. So he's going into a heart block, is it? What's the rhythm?
What's the rhythm?
I've got no pressure. Who's got no pressure?
And the pressure?
There you go.
Can we give some metaraminol? Should we give? He's going in at a
Back-
block.
should
Should we
back
give some
the guard out?
atropine?
Oh, not that's.
Might be a good idea.
I wonder whether we're just.
Is that better?
It's a bit better.
That is better, Dan. Well done. Have you given anything? So was that the guide or was it him?
Not sure. That would have been a very quick effect. Well, we'll see in a second. It was if it was the guide, then that's raminol will kick in and we'll have a very high blood pressure.
So I do. Maybe the guide being in caused spasm there. It doesn't look like we've done any.
No, I don't think we've
Injury
done
to
that.
it.
Yeah. We
My
can leave it.
inclination is not to chase this
Yeah,
proximally
no, I agree.
and to just try and
Should we just take
optimise
the-
it a little bit better.
Take the 3.0 and then get out.
Yes.
Yeah, I agree. Well, we've still got the left side of disease that we haven't.
That we're gonna
Right, we've got the
figure out
3.0.
what next to do with.
So the ACT's gone. This is the 3.0.
Pressure's much better. I think it was a combination. It was the guide, wasn't it?
12.
Okay, and down. Okay. Good. Okay, 2020.
We're done then.
Yeah. Okay, so we have an intubated patient who the ECGs looked like the culprit was the right. It behaved as a more of a chronic occlusion, but with thrombus.
Yep.
And we have opened that vessel. Now he does have bystander or other disease in his circumflex intermediate and LAD.
Yep.
What would be the evidence to move on and do that now?
Yeah, I think out of the context of arrest and cardiogenic shock, I mean, he's on inotropic support and intubated, as you said, so if he was a stable patient, there'd be reasonable data to fix the bystander disease either now or at a staged interval within the next couple of weeks. But I think in the context of an arrest and inotropes, the data would support medically managing him now and reviewing it at a later date in terms of complete revasc.
I'm in agreement with that. There is a little bit of a proximal narrowing here, isn't there?
There is a
My inclination is to leave that alone.
yeah, we've got
Looked
2 and
better
3 flow.
previously. Next, so there's high marginal or diagonal. It could be intermediate or diagonal, isn't it, on this view? Next picture. And then we've got on mid LAD. Next picture. Next.
Yeah, it's a dominant right, isn't it? Small circ.
Next.
Mm.
So do you think it's very reasonable to
I think
let
it's
him recover
reasonable to recover him.
and then bring him back as a planned staged,
Yeah.
potentially as an inpatient, depending on how
Yep.
how
I
he's
think so.
progressing?
If he recovers well a night a year, I think before he goes home and fixing the LAD.
Yeah, and
plus the
sometimes
circ
we
makes
see these
sense.
vessels pick up.
Yeah.
When
We can reassess the right as well if the the proximal disease.
we,
Can
okay.
always reassess that at the same time.
Excellent. So we're gonna
Do an allogram.
and
Mm.
as we were predicting, but the anterior wall looks to be working
Yeah,
reasonable. So I think that there would be an advantage to secure the
I
LAD.
agree. Yeah.
And
I think so. Agreed.
so Dan, while our anaesthetist is getting a radial line, this, if I summarise, this is a 60-year-old gentleman that
Flush, please.
became acutely breathless at home and
Correct.
collapsed. 5 minutes later, he was resuscitated initially with asystole, then PEA,
Correct.
and then gained output. He had ST elevation in the inferior leads with ST depression in the lateral leads and came intubated to our hospital, Bart's Heart Centre. He was taken direct from the ambulance to the cath lab, where we performed a right femoral angiogram because of peripheral shutdown, the radial pulses could not be felt. This is shown in the left system, intermediate stroke diagonal vessel with a severe stenosis, a mid LAD with a severe stenosis, and then an occluded right coronary artery that was filling retrogradely, and what appeared to be, when we were trying to cross the lesion, a chronic occlusion that we managed to navigate with a crossair and a whisper MS wire. This was pre-dilated and then a 275 x 48 drug-eluting stent where the drug can elute within a month was deployed, and this was post-dilated with a 275 and then a 3mm non-compliant balloon, opening up the tight area in the middle of the stent in particular. He's now got a stable blood pressure. ECG ST segments have resolved, and our plan is to stabilise him, extubate him, and then bring him back for a planned stage procedure to the left system.
Yep.
We will have given aspirin intravenously and 2B3A in the form of integralin and heparin, maintaining an ACT above 300. And the plan is to put an NG tube and give ticagrelor with aspirin, dual antiplatelets, for at least a year, but with the stent that we've put, if there are any bleeding concerns after 4 to 6 weeks, we can go to one antiplatelet agent.
Yep.
And full secondary prevention. Is there anything else that you have any concerns, or when he comes off of the table?
No, I think you've covered everything, and obviously we're going to angioseal the right femoral closure rather than manual pressure as soon as the ITU staff have sighted an arterial line for monitoring.
That's right. Excellent. Thank you. Right. So,
We need to just sign out. So this chap's had one drug-eluting stent to a blocked right coronary, right femoral. We'll seal the leg after the arterial line's gone in prior to him leaving the lab. He needs integralin for 4 hours after the ticagrelor is given down the NG tube to make sure it's effective, so probably at least 6 hours. And he needs to come back for staged intervention to the LAD at a later stage. And the contrast was 280. Everyone happy? Any questions?
No, thank you.
Great. Thank you.